to Sanket for extensive coverage approach to hypercoagulable state and principles of management. I would just like to ask you, just can you elaborate on unprovoked and provoked thrombosis? Can you elaborate on that?
So unprovoked or provoked. So provoked is basically whatever the risk factor that we have discussed. So patients who already have taking the estrogens or OC pills, or those with the immobilization, those who have done the long hours of flight journeys, or those like post-op or postpartum pregnancy, all these are considered as a provoked factor. However, when there is no such history and suddenly patient presents with the one fine day present with the DVT, it is considered as a unprovoked. Some question answers.
First question is why APTT is prolonged now patient have thrombus in vein?
Classic question by consultant. Okay, so it is not always that APTT is prolonged in case of thrombus, but as I have mentioned, there are few conditions, particularly this EPLA syndrome. Lupus anticoagulant preferentially causes prolongation of phospholipid-based test, that is APTT. It is a one condition. Factor 12 deficiency is also another important factor which is associated with the APTT prolongation. So these are the few factors where there's APTT is prolonged and still there is a thrombosis.
Any expert comment on management of thrombosis associated with Behçet's disease?
I haven't come across this anyway, but what I feel is probably Behçet's disease is an acute inflammatory condition, so you have to treat both the simultaneously. If you have thrombosis, particularly of venous or arterials, then you have to have particularly large veins or DVTs. You need to have anticoagulants along with the treatment of Behçet's, that is the immunosuppression.
Next question is, in cerebral venous sinus thrombosis, can we start DOACs after low molecular weight heparin, or BKA is only preferable?
So as I mentioned, there is data which is coming up. There is Rivorexaban one trial and one trial from Dabigatran which has shown non-inferiority. However, most of the guidelines still does not prefer DOACs or vitamin Ka. They are considering at least 2 to 3 months of LMWHR and then you switch over to warfarin. Particularly when if you have EPLA, you better not to go with the DOACs because the data in one trial was actually inferior. But other data are coming up and probably in the next 2-3 years, we will have adequate data whether we can switch over or not.
MPN is a myeloproliferative neoplasm. So somebody has asked the long form of MPN. There were so many short forms in lecture. So please use full forms that somebody has mentioned. A patient in ICU is intubated for DVT prophylaxis. Can we give DOACs directly?
Patient is in ICU intubated for DVT prophylaxis. Yes, I think you can give. There is no issues with that. If he is bleeding, then the stocking will be the better option.
So the routine prophylaxis is it indicated in ICU patients, all ICU patients?
Well, on all the ICU patient, it is not indicated. Probably those who are in the long term in the ICUs, probably 7 days, 10 days, those patients are more important. Rather 1 or 2 days, like your cardiac patients or COPD patients who are coming into the ICU, probably I don't think so.
The prophylactic measures are better than, I think, to use drugs. The second question is protein C and S should be avoided in Indian patient?
It is not said that it is avoided. Protein C and S are seen in the Indian patients. It is the factor 5 laden and the prothrombin gene which is very rare in the Asians. So I will not say that we should avoid, but it is the timing when we should do it is more important. During the acute thrombosis or when you are on anticoagulant, this testing will not be that much useful. You should at least wait for 3 to 4 months of acute.
I think before starting secondary prophylaxis,
yes, exactly.
You should give some period and then this test should be done. Which and what dose, at least for what he has asked. Which and what dose, any overlap with LMWH required. That is, the question was from Smith was, can we start DOX after LMWH or VK is only preferable? And then he has asked further, which and what dose.
Okay, so I'll go with the warfarin only.
Overlap is standard, so you have to overlap till the prothrombin time is prolonged, and then you can switch over to warfarin. Is there any difference between warfarin and acetro?
I don't think so.
Both have a similar action. So, and those for ICU DVT prophylaxis.
ICU DVT prophylaxis, you can use a lower dose of rivaroxaban like 10 mg. It's good enough.
Can use low dose, low molecular weight heparin.
Yes, you can even use the low molecular weight heparin. Previously, it was even LMWH is commonly used. It is just because now orals are available that we are switching over to that.
Can we start low molecular weight heparin and warfarin on day 1 and stop LMWH after 3 days? No, this is common, I think, for all anticoagulant therapy. Probably this is asked.
Yeah. I think I have not used that way. I usually start with LMWH for a few days once the patient stabilizes and then start overlapping. 2-3 days I'll go with that way only LMWH to see how the patient is behaving and how the response is there, if there is any deterioration or something.
Question answer. Sir, can you clarify about provocative factors not to be forgotten while ruling out cause of CS with DVT? Is there any guidelines available?
Provocative factor remains the same for everything, but obviously when we are talking about CSVT, the immobilization, all that won't come. For CSVT, it is the pregnancy, OC pills, hormone replacement therapy. These are the major factors which will be considered. Even
I think somebody will ask CSVT long form. CSVT is long form for CSVT.
it probably cerebral sinus venous thrombosis.
What should be the duration of anticoagulation if no obvious cause and thrombophilia profile not available?
Lifelong. So that is a big.
Even if there is one episode,
yeah. So that is a most difficult question to be answered because only one episode and how to manage that. But as per the guideline, if it is unprovoked, there is always a high risk of second recurrence. As I have mentioned, the risk of recurrence is as high as 50% in the 10-year wave. But to convince a patient or even for a doctor to get convinced that this patient, just because one DVT is there, we will give them long-term prophylaxis is very difficult. Usually what we do is at least 2 to 3 years of anticoagulants, and then maybe go on the stopping sometimes in clinically, sometimes, and then we'll see if it recurs, then it will be lifelong. I think, sir, you will be better answerable.
I usually don't give lifelong for the first episode. So usually 3 to 6 months, and then if there is no other clinical indication to continue, then I give one chance and stop after 6 months. And if there is any time, any condition, second episode is there, then it is lifelong. Like stroke patient already on anticoagulant, we can't omit it. So when we do protein C or S or homocysteine.
Yeah, so exactly. But again, doing that, will it change anything for your management?
No.
So even testing to that, rather than test, you are going to give it for lifelong. And probably in the stroke, usually you give the anti-platelets rather than anticoagulants.
level can acute thrombosis, can we get it in acute thrombosis? Antithrombin 3 level, can we get it in acute thrombosis?
So in acute thrombosis, we cannot do anything. And it is, as I have mentioned in one table, antithrombin 3 level cannot be done in any thrombosis or even on the heparins or anything. Protein C and protein S can be tested when you are on heparin, but not on the warfarin or DOAX. Again, in the DOAX, you can do the antigen level, but not the activity level.
How important is to achieve APTT while treating for TBT? I think we never see APTT except when we are in unfractionated heparin.
Yes. So if you are doing with the unfractionated heparin, going with the drip, that like in the certain cases of cerebral venous sinus thrombosis, you are doing it, then it is most important because your therapeutic efficacy depends on that. So you have to have get 6 hourly APTT done, you get the results, and accordingly you have to adjust the dose of heparin. But nowadays, most of the games we are using LMWH or NOX, so I don't think so that is now much of the required other than cardiac bypass surgeries and all kind of that things.
Same target APTT for myocardial infarction, DVT, pulmonary embolism. I don't understand the question. That is all. So no more questions. I think all the questions are covered.
I got one thing. We have someone has raised the hand.
Questions, probably two questions have come. We have patients on warfarin with unstable INR. Is it advisable to use DOAC in such patients?
First of all, why you are using warfarin? The reason for thrombosis, is it DVT, PE, or any other thrombosis? And again, even if warfarin you are not achieving the results, then it's better to you can switch over in case of DVT or PE. In case of the others or in case of EPLA, you need to go with the warfarin still because the data with the DOAX is still inferior or non-inferior, but not the superior. Most of the time we are not getting adequate results because of the various patient-related factors. So we should try to find out all those factors, whether patient taking properly or not, the food habits and all that things, whether she's or he is changing it frequently, and the dose. Probably most of the time we are using 5 milligram or 6 milligram, and then if we are not achieving, we are getting worried. But somewhere I have seen that even as high as 10 milligram of warfarin is also required to achieve the adequate level in some patients. So we have to use that kind of doses.
Lifelong anticoagulants for unprovoked one episode of CVST, or should we go for repeat MRI and then decide?
There is no role of recanalization or anything in life. It should be lifelong because cerebral venous sinus thrombosis is something which is life-threatening if it recurs and if it recurs in larger area.
So if it is unprovoked, it has to be a lifelong.
If it is provoked, yes, drug-induced or something, you can stop it.
No further questions. Yeah, I think we have covered all the questions.
Should we consider hyperhomocysteine as provocating factor for venous thrombosis? Very vague factor, and we should not attribute it as a provocating factor unless you have, as I have mentioned, the levels is very high. Most of the time our values are 15, 17 to 18, and that is not a causative factor. It is just a supportive role, or it might be the acute thrombosis has increased the level, which might come back to the normal, and we attribute it to the homocheck or whatever we are giving, and we think that because of the drug the level has come down, but it is actually the acute thrombosis event has gone and the thrombocysteine has come back to its normal level.
I think that's all.
Yes, sir.
We are well in time. We have finished within 1 hour.
So next topic will be DIC by Dr. Abhay Bhave. Sir.
Bhave, I think, is a senior hematologist from Bombay and also visiting Lilavati Hospital. He is a very senior, very good orator and senior hematologist. I think we should, Sanket, we should also cover this drugs part DOX and means as an anticoagulants.
Yes, sir. Next one.
Separately, yeah.
We will keep one session on DOX and we will keep one session on apply itself.
Ah.
Sure, sir.
That will again repeat the management because the management part is so important.
Yes, yes.
To cover it again also.
Done, sir. Sure.
Okay. So thank you very much, and we'll end this session here.
Sure, sir. Sure. Thank you. Thank you, everyone.